Thank you everybody for joining us today. Today's webinar series, of which there will be two in this series, is our last series for the year, and the title of which is Safety for All. And we're going to focus on safety for the patient and the healthcare team in the operating room and the CSSD. The webinar series is brought to you by SafMed, and SafMed has been your solutions partner in both the CSSD and the operating rooms for over 35 years now. Just as a reminder, SafMed has a YouTube channel, and on there are all the SafMed education webinars as well. We have over 35 webinar recordings loaded on our YouTube channel. We've had over 7,760 views of those various recordings. So it seems that our material seems to be educational and of great value. The series that are loaded there, including things like effective cleaning, rigid endoscopy, track, trace and instrument management, maintaining sterility, cleaning chemistries, sterile barrier systems. All these series are available on the YouTube channel. If you'd like to do the post-webinar tests and receive a certificate, please just drop me an email. I'll send you the links to all of that information. As I said, today's webinar, we are going to talk about safety. We're talking about safety from a CSSD perspective, and we're going to talk about safety from an operating room perspective. And over and above that, we're going to look at it from the patient's perspective, as well as from the healthcare worker's perspective. So taking everything into account, a lot of information to cover, so let's dive into it. In order to be safe in any of these environments, both the operating room and the CSSD, it's obviously quite important that we understand what the hazards are. And there are a multitude of hazards in our working environment, both for us and the patient. But in this particular slide, we are referring to the hazards in the operating room and the CSSD from a healthcare worker perspective. So, the risk for us. We can divide them into 6 main characters or 6 main categories: chemical, biological, ergonomic, physical, or psychological. From a chemical perspective, things like high-level disinfectants, bone cement, sterilizing agents, cleaning agents, all of these can be hazards. Biological hazards will include pathogenic microorganisms, all sorts, of course, including things like hepatitis, HIV, maybe even Creutzfeldt-Jacobs disease. Ergonomics, standing, pushing, pulling, lifting, awkward positioning, lighting all play an important role. Physical hazards will include slips, trips, falls, sharps, burns, noise maybe, electrical issues, surgical plume and fires. And there's psychological stresses, which can include abuse, techno stresses, impact of aging perhaps, and shift work. All of those very important to us in these environments. But what about the patient? Yes, the patient is also at risk, of course. The patient is at risk when it comes to various chemistries, including bone cement, high-level disinfectants, cleaning solutions. Biological issues, of course, we can transmit pathogenic microorganisms to the patient via our instruments or directly from our own hands. The patient is at risk for all sorts of injury when it comes to poor patient positioning, perhaps pressure injuries, musculoskeletal injuries, injuries to the eye, all sorts. Physical, patients at risk for falling off the table, slipping maybe, potential for burns, electrical issues, fire, retained surgical items, and injury as a result of noise as well. And then from a psychological perspective, of course, they get cold. Tend to get cold. It's a high stress environment, and it can also be very noisy, which has its own psychological effects as well. Well, when it comes to managing risks, what do? We always refer to the hierarchy of controls, and there are a whole multitude of things that we can do to manage risk, but we always want to start with those that have the most effective results, and we'll take it down to those that tend to have the least effective results. So we talk about, can we remove the risk or eliminate the risk? That would be really great. That's our first golden answer, if we can. If we can't remove the risk, is there something that we can replace or substitute? So if it's something that we're using currently, is there a safer method of doing it? The third thing we will look at is the various engineering controls. The fourth thing we'd look at is the administrative controls. And then the last thing to put into place in these hierarchy of controls is PPE, for example. So let's use an example of a high-level disinfectant, using a high-level disinfectant in the operating room. Can we remove the risk? Is there perhaps an opportunity that we could use a low-temperature sterilizer and maybe not necessarily use a high-level disinfectant? Or do you have a set of circumstances where you have to use a high-level disinfectant, you have no choice? If you're using a high-level disinfectant, can you maybe replace it with a safer one? Are you using the safest one possible for both the patient and yourselves? If that doesn't work and now you have to use a high-level disinfectant, if you are using it, what engineering controls can you put into place to make sure that you're using it as safely as possible? And that would include, for example, good ventilation maybe. Then what administrative controls can you put into place? So what standard operating procedures may be and how to use them correctly. Things like testing the minimum efficacy of concentration or making sure that you rinse correctly. Those are all administrative controls and written policies and documents around how to use the product correctly. And then what PPE would you apply or use for yourself? Obviously then gloves and certainly eye protection, etc., and the rest of the standard PPE you're going to be using in the operating rooms anyway. So those are managing risks, trying to ensure safety. Those are the processes and steps that we want to put into place. But let's dive a little bit deeper and let's take some detailed look at some of the things that are potentially an issue. We won't cover all of the aspects I raised in the beginning, but we'll certainly focus on as many as we can. What about bone cement? So the risks associated with bone cement were reviewed in this publication in the ARN journal in 2021. So one of the members wrote into the journal and they asked, what are the components of bone cement and are there any precautions for the operating room staff specifically that they should follow when handling bone cement? So I don't know about you, but we certainly definitely used to spend as much time as I can playing with the bone cement, like it was Play-Doh, and seeing what little figurines I could create. I like to try and make animals. They weren't very good, but that's what I would spend time doing because it was fun. So I thought. But of course, bone cement can be tricky. It's commonly composed of methyl methacrylate. I think I said that correctly with a bit of luck. So the acronym MMA is the liquid section. And then, of course, there's this polymer powder that we need to mix together. And during that mixing, high concentrations of MMA vapors are given off into the air. And that can have terrible effects for those working with the product. I personally have never read a set of instructions for bone cement, which is pretty poor, and I do believe one should have at least read them, because bone cement can cause irritation to the skin, to the eye, to the GIT system, to the respiratory system, and there are limits. We are not supposed to be exposed to more than 100 parts per million per 8-hour shift. And do we know what we are actually exposed to? Of course, it's not always possible to eliminate the exposure to that, and obviously the surgeon will take into account whether or not to use bone cement because they're well aware of the risk to the patient. But if not, what are the controls that you could put into place when you are using bone cement? Because, of course, we can be exposed via absorption through the skin, via ingestion or inhalation. The adverse effects that it can include can occur to the patients include hypertensive episodes and cardiac arrests have also been reported. As we said, the orthopedic surgeon is going to do a risk assessment around that and make their own decisions on whether or not this needs to be used. What do we do to reduce exposure? Well, follow the manufacturer's instructions for use. Could we read them? as I said, I sadly have never read one, and I really should. We want to ensure effective ventilation in the area that we're working in. So if it is in the operating room, where it generally is, where you're going to be using the bone cement, make sure there's nothing blocking the vents. Make sure the aircon is working correctly. You haven't got trolleys and bits and pieces up against the extraction vents. Wear the correct PPE as normal, gloves and eye protection. Wear double gloves. Limit the handling of the bone cement and only handle it after it reaches the dough stage. Tricky, because obviously you have to stir it a bit. Change your outer sterile gloves immediately after handling. A very important concept. And if there was a spill, that's a whole nother entity and very important to manage that. Ask ignition sources and cover the spill with an activated charcoal absorbent material. Here's one, an article published in the British Medical Journal, a case report of an incident using an OPA-based high-level disinfectant. It was a case where a 5-month-old girl had an echo procedure done, and after the procedure, she developed this black lesion, the damage to her skin and her lips. That was the initial, and then 18 days after exposure, they found a fur-like, they referred to as a fur stuck circumferentially in her esophageal membranes, which actually was some form of fungal growth from resistance. And then 172 days later, she had severe stenosis. A really horrible scenario that they had to deal with, and a case report of when things do and can go wrong. In terms of the OPA. The conclusion in the report included the fact that there was insufficient washing or cleaning of the probe before it was even soaked in the OPA, one of the issues. The other issue they referred to was soaking for a prolonged period of time, so not following the manufacturer's instructions for use. And I'm aware of the fact that a lot of people do that. If they think there's some weird, wonderful microorganism that they're worried about, we'll soak the devices for longer than what is recommended, sometimes even overnight, and we do strange things like that, and it's really not ideal. And it goes on to report about the fact that a small amount of residual OPA could possibly cause damage to skin and mucous membranes. There are also some IFUs and OPAs where they talk to the fact that patients that have CA should not be exposed to OPA type high-level disinfectants. So we tend to use them a lot, and we need to manage them correctly. Very, very important if you're using a high-level disinfectant to follow the instructions for use. I think that's the basic premise for the majority of things, isn't it? The ARN guidelines, a quick review of the guideline on high-level disinfection and management of high-level disinfection. And I know you know this, you really and truly do this every day. And simple but important reminders, of course, to follow the manufacturer's instructions for use, to test the minimum efficacy of concentration, to disassemble the item to be processed, to clean, rinse, and remove visible water prior to actually immersing, and of course then eventually immersing in the high-level disinfectant solution. Ensuring that the item is completely immersed, flushing and filling the lumens, in immersing it for the full duration as per the manufacturer's instructions for use, as well as not immersing it for longer than what is recommended. Rinsing the item as per instructions for use. There are some OPOs at one point that had an IFU that said 3 separate rinses. Perform high-level disinfection in a designated clean area that's separate from the decontamination area and separate from the locations where patient care activities are performed. As you know, if you look at the images on the left, we can see where the high-level disinfectant hasn't been managed correctly. The lid being left off quite often, and you can see a whole accumulation of fluff and instruments that haven't been properly soaked. Of course, there's the biological hazards we spoke about earlier, and what can we do? we need to protect ourselves, don't we? And it includes restricting access to areas so that people and visitors don't get exposed to potential biological pathogens, having, of course, safe working procedures, having good infection control policies in place, as you know, wearing all the correct PPE, as you would, making sure everybody's well educated, and don't forget the immunization programs like hepatitis, perhaps a very important concept. We can expose our patients to biological materials, as we said. Think about it, laparoscopic instruments that are so complex, if we don't clean them properly, we're putting our patients at risk. A point always important to remember, of course, that in laparoscopic surgery, we've got this positive pressure of the CO2 and this inflated abdomen that can cause blood and body fluids to fly up our various channels of our lumens, making it quite complex. So think about proper cleaning with proper lumen flush. When you're using an ultrasonic cleaner, it's quite possible that there will be bacterial aerolization, and that's a risk. That's why some of the bigger models you'll see have got a function on them that if you open the lid, the sonics will stop working straight away and possibly even abort the cycle, depending on the make and the model of the type of machine. The smaller ultrasonic baths don't tend to have that safety feature on them, but if you're using those baths for eye instruments or smaller devices, please, 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 please keep the lid on, else you're potentially exposing yourself to microorganisms. Okay, so what have we looked at? We've looked at chemical hazards and we've touched on some of the biological hazards. So now we're going to move on to ergonomics. So ergonomics, of course, is the study of people at work with the goal of preventing soft tissue injuries and musculoskeletal disorders. It's well documented that poor ergonomics can increase the risk of musculoskeletal injuries and impact a surgeon, or us for that matter, our performance in the operating room. That incorrect posture can lead to fatigue, discomfort, stiffness, numbness, back, shoulder, neck, leg, injuries and problems, as well as long-term disabilities and the need for corrective surgery. Certain factors inherent in our tasks that we do every day will put us more at risk, and that includes fixed and constrained postures that were frequently awkward, uncomfortable, and maintained for a long time, and that is 100% what happens in the operating room. Repetitious and forceful hand movements, a high pace of work. Of course, certain medical conditions will make it particularly worse or increase the likelihood. Things like having predisposed to having arthritis, diabetes, or thyroid issues, and even smoking can make your risk a little higher. Alrighty, so now I'm going to play a video, and hopefully your internet connection's okay and mine stays okay. This video is 8 minutes long. If you have issues hearing it, please be patient for 8 minutes, and you will definitely be able to hear it and view it clearly in the recording. Of course, as normal, we will send a link to the recording after the session as well. But this very informative video looks at ergonomics in the operating room. Really interesting version of things. Here we go.
A variety of operative approaches are available for gynecologic surgeons, including laparoscopic, open, vaginal, and robotic, and all require the surgeon's body to move through and maintain a variety of positions. The physical nature of surgery necessitates an awareness of ergonomic principles. However, adequate knowledge of such principles has been reported to be as low as 11% among practicing surgeons. Findings in the literature, based primarily on reports of general laparoscopic surgeons, indicate high rates of neck, shoulder, and back pain, as high as 89% in one study. Sadly, for many surgeons, pain is seen as part of the job rather than a warning that postural and environmental adjustments are warranted. Fortunately, many of the factors that contribute to the pain surgeons experience can be improved through education, modification of OR setup, and changes in surgeon posture. The following elements of the operating room environment must be considered: monitor position and height, table height relative to each surgeon, placement of arm boards, and location of foot pedals. The position of the monitor directly affects back and neck posture for all surgeons involved. The display should be directly in front of each surgeon, 15 to 40 degrees below eye level for maximum comfort. Higher monitor placement requires the surgeon to compensate with extension in the cervical and possibly lumbar spines. When determining proper table height, the additional height contributed by the patient's body must be considered. Table position that is too high requires the surgeon to make unnecessary compensations through the shoulder girdle that create increased load and mechanical disadvantage. Table height should be adjusted to allow 90 to 120 degrees of elbow flexion. In some cases, this may require one or more surgeons to stand on steps. The common practice of placing arm boards at 90 degrees from the patient's body can challenge the surgeon's ability to achieve and maintain optimal ergonomic posture. When possible, tuck the patient's arms, which allows for more natural and ergonomically sound surgeon movement. Foot pedals should be placed next to the surgeon's foot and aligned with the target instruments toward the target quadrant. Positions that cause the surgeon to twist the leg or body should be avoided, and assistance may be required to readjust the pedal position. If the surgeon is standing on a step, the pedal must be at the same level off the ground. Along with this basic understanding of the ergonomic importance of proper OR setup, 3 common ergonomic errors in surgeon posture will be presented. These include forward head posture, sustained and awkward shoulder elevation, and asymmetry in weight bearing. Head forward posture is a common cause of tension and pain in the upper body. It can accelerate degenerative changes, particularly in the mid-cervical spine at the segment supplying the shoulder girdle. For every inch the head moves forward in space, its relative weight increases by 10 pounds, upping the demand on muscles and joints for adequate support. Developing a practice of habitual postural resets is recommended. Excessive and sustained shoulder abduction and internal rotation is non-optimal for many reasons. This position requires the greatest workload from the deltoid and trapezius, creating a mechanical disadvantage and predisposing to fatigue and injury. The postural reset here is to drop your shoulders and relax the hands. In the OR, surgeons commonly shift their weight and will stand on one foot, frequently due to foot pedal use. However, this habit can have significant implications for the pelvis and lower back. When the majority of the body weight is on one lower extremity, excessive shear and load in the structures of the lower extremity and spine can result, contributing to pain and injury. The proper position to avoid these issues is to keep the feet approximately hips width apart. Avoid shifting weight to one hip. Be sure not to lock the knees. Rather, when weight is shifted asymmetrically, gently engage the deep muscles of the trunk and pelvis to maintain a neutral position. Footstools can be used, provided that proper pelvic and lower extremity position is maintained. Again, avoid shifting weight to one hip, which leads to asymmetrical loading through the lower extremity. Given the sustained nature of many surgeons' postures, it is helpful to periodically move the body into counterbalancing positions during any natural breaks in surgery. An arm raise, as shown here, uses full shoulder elevation, external rotation, and scapular depression and retraction to counterbalance the habitual upper body positions previously described. Draw the scapula down and back toward the middle of the back as the sternum lifts slightly with bilateral or unilateral arm raises. Squatting, as if sitting back to a chair, is an easily performed multi-joint functional exercise that engages the large muscles of the lower body and reinforces symmetrical weight bearing and neutral spinal position, all without compromising the sterility of the operative field. It has been suggested that robotic surgery confers ergonomic benefits for the surgeon over both open and conventional laparoscopic surgery. However, proper attention must be paid to ergonomic principles while the surgeon is seated at the console. In particular, proper posture and upper extremity position at the console are crucial in order to avoid neck, back, and arm strain. The robotic console requires the forehead to rest on pads while viewing the operative field through the 3D high-definition vision system. The forearm should rest comfortably on the arm supports, the torso should be erect, and the feet should be comfortably placed on the floor. If adjustments are not made to the seat and console height, the surgeon may be forced into an awkward position of the spine, neck, and upper body. Without proper adjustment that is individualized, forward head posture and improper shoulder positioning will result and be sustained throughout the case. Adjustments of the seat height and proximity to the console can yield marked improvements in posture without compromise of the visual field. To avoid muscle strain and fatigue in the shoulders and elbows, it is crucial for the surgeon to remember to keep returning the arms to the arm supports and to frequently engage the clutch mechanism on the hand controls. We suggest that consideration of OR setup, proper standing posture, practice of postural resets, and regard for sitting posture and upper extremity position during robotic surgery are necessary components for a longer, healthier, and pain-free surgical career.
Excellent. So hopefully we learned something out of that video. The American College of Surgeons also released a surgical ergonomics recommendation booklet. You can find it with a quick search on the internet, and in there you can see the graphic with the suggested height for laparoscopic surgery and for open surgery. Obviously it needs to be relative to the height of the surgeon, and that's why a table that can adjust to the various height needs, both really low and somewhat high depending on the surgeon and the patient, is quite a crucial aspect to consider. You saw the fatigue to the shoulder. The guidelines talk about ensuring that at least half of the instrument, the laparoscopic instrument, is inside the patient, because that will help for less excessive motion of the shoulder and hopefully less fatigue for the surgeon. In this journal publication, published in the journal Multidisciplinary Healthcare, titled A Review of Musculoskeletal Disorders Amongst Operating Room Personnel, they go on to talk about things we really understand already. Of course, that pulling and pushing and lifting and moving heavy specialized equipment and patient positioning are the most common manual activities in the operating room. Of course, due to the difficult working conditions, musculoskeletal disorders are common amongst operating room personnel. And they say that statistics show that 7.5% of nurses are absent from work each week due to physical disabilities. So managing these disabilities and these physical issues can hopefully help us all with our staff contingent. Physical ergonomic risks, according to the ARN, include lifting and moving patients, equipment, supplies, of course, multiple lifts per shift, solo lifting, twisting, using inappropriate body mechanics, prolonged computer work, also a relevant point, working in unsafe physical settings, wet floors, inadequate lighting, using broken equipment, and of course, wearing lead aprons during surgery are all particular hazards that we need to work with. Physical stresses in healthcare settings, such as awkward positions, as we said, can contribute to musculoskeletal disorders. The ARN states that when perioperative team members must stand in the same position for longer than 2 hours continuously, or for more than 30% of their workday, that we should be using some form of fatigue-reducing techniques. And those include, for example, correct placement of monitors. So we need our monitors on arms that can move and be placed in the right positions. And of course, designing the theatre around that is also very important, that the monitors don't clash. The height of the operating table is going to be very important, that we can adjust that. alternating, propping one foot up onto a footstool, and we heard now that how to do that in the video, wearing supportive shoes, and maybe thinking about things like anti-fatigue mats. Of course, we can transfer patients multiple times in a day, especially if you're on a gynae or urology list or something along those lines. And we're not only transferring laterally, but we're also putting up patients into lithotomy all of the time. The guidelines, as you can see from the graphic, state that if a patient weighs more than 50 kilograms, then 4 people must be involved, as well as the use of some form of transfer device. So talking of transfer devices, obviously makes sense to make use of technology. So maybe think about carts to store and transport table accessories, both for safety and to minimize lifting. Think about maybe using this kind of lightweight insert onto the table. So when you're putting a patient constantly into lithotomy, you only have to remove this lightweight section, foot section, instead of using the heavy legs the whole time. In the CSSD, yep, lots of prolonged standing, potentially awkward position, repetitive tasks, heavy sets, non-ergonomic chairs, non-ergonomic work surfaces, deep wash basins. Solutions, of course, include sit-stand stools, height-adjustable workstations, trying to manage those heavy sets, rotation of tasks so that you're not doing the same thing all of the time, maybe a footrest bar, correct footwear, worrying about the basins, maybe washing in a washer rather than a basin wherever you can. And I said managing those heavy sets. When we're pushing and pulling stuff, please remember to keep your wrist in a neutral position. If you look at the pictures on the top, both those people who are pulling and pushing those carts are really and truly not doing themselves any favors. Note the neutral position of the wrists on the bottom 2 images. So when it comes to lifting heavy items, because we do have heavy items to lift, including patients and heavy sets, I'm afraid, hopefully we can manage those better. There's an important concept known as the power zone. So that's lifting in a manner that's closer to the body to protect yourself. There's a short video that I'm going to show now, which is a minute long, that's going to describe that power zone. So hopefully we can lift a little more safely.
A safety short from the ATA Workers' Compensation Fund.
In this video, we are going to look at some specific tasks required when loading and unloading product. Before we do that, it's important to understand one of the fundamental safe working methods in any material handling task. That is the concept of the power zone. The power zone, which may also be called the safe zone or comfort zone, is the area within your range of motion that gives you the maximum strength capability with the most comfort. It is the zone close to the body between mid-thigh and mid-chest. This is a zone where arms and back can lift the most with the least amount of pressure. It's similar to the strike zone in baseball. Employees have fewer injuries when working in the power zone, and they can maximize the strength and comfort and minimize the forces applied to the muscles and joints. It's not always possible to work within the power zone 100% of the time, but the more you can shift a task to this area, the more effective and safe you will be in your job. It's also important to reduce your in-range motions whenever possible. End-range motions occur at the extreme limits of a body part's movement. You can eliminate or minimize in-range motions by improving body position. Some other tips to follow are to position your feet correctly, squared and aligned with the object, about shoulder width apart. Get close to the object, bend at the knees, keeping the natural curve of the back. Always test the object for weight or shifting of contents. Get a firm grip and grasp opposite corners. Always lift with a smooth, steady motion and don't jerk. Move your feet, step or pivot, don't twist. Now let's look at some specific tasks a driver faces at the terminal and when loading and unloading product.
So if you think about the power zone over here and the setup in the CSSD, the storeroom, very important, where we store our heavy sets. We don't want to be lifting heavy sets from low heights, or from that matter from higher heights. It might make it easier for you, certainly it will, if you can store your heavier sets at around waist height. Using a system like the shelving on the left, where you can pull the tray out, will also make it a little bit easier, instead of having to sort of stretch deep in and use awkward positions and awkward motions. So what have we spoken about today? Including our brief break, we've focused on how to manage and control a variety of risks. We've spoken about the chemical hazards. We've spoken about using engineering controls, administrative controls, and the use of PPEs. We were reminded of various chemical hazards like bone cement and high-level disinfectants. We spoke about biological hazards, and those are difficult to manage, but of course, good PPE is going to help us with that. We've spoken about properly cleaning devices to protect our patients from contaminants, the importance of using ultrasonic cleaners for complex and lumen devices. We've spoken about aerolization of microorganisms, why it's so important to keep the lid closed. It also includes why it's so important when you're washing instruments to wash below the waterline. We do not want to aerolize microorganisms. There, of course, the value of having an ultrasonic bath that stops the sonics automatically when you open the lid. We've spoken a lot now about work-related musculoskeletal disorders, lifting and transferring and positioning patients carefully, and lifting in the power zone. Next week, we will go on to cover more around ergonomics and positioning, also around positioning at a computer setting, because lots of us do need to work in an office environment. And then we'll talk quite a lot more around the physical risks, including burns, surgical plume, fire. Got some interesting information around that. And we'll also focus a bit on psychological issues, mostly around abuse more than anything else. But don't forget that there are impacts from aging, there's impacts from shift work, there's certainly impacts from technological stress. Thank you so much for joining us today. I hope that you enjoyed this presentation. And we will be sending out in a day or two a recording of our session, as well as a link to the test. If you take the post-webinar test, you will, of course, receive a certificate of attendance. Thank you so much, and see you next week, same place, same time.